So foot drop. Foot drop, this is a common case that is kept as short case for examination in orthopedic vivos. Fibular nerve neuropathy is the most common mononeuropathy of lower limb, and unfortunately for unknown reason it is the most common nerve injury in the various surgical procedure. So diagnosis. My clinical diagnosis is a 37-year-old male with non-recovering complete peroneal. In revised terminology, the term peroneal has been replaced by fibular, and this latter should be preferred. Nerve palsy of right leg for past 3 years following injury to the proximal leg region, or knee dislocation, or post-gluteal injection, or post-surgical total hip replacement, or spine surgery, or leprosy. Whatever tell the reason. Note: foot drop is a clinical finding and not a clinical diagnosis, so it should not be presented as a diagnosis. Finding: in history, the patient has complained of limp and need to unusually raise the foot of involved limb to clear the ground. The patient also complained of catching of toe with ambulation. There is associated sensory loss over the dorsum of foot. Weakness or absent dorsiflexion at ankle. Foot drop. So figure Dutchney test. Weakness or absent dorsiflexion at ankle. Foot drop. Weakness, absent great toe and other toe extension. Weakness of foot eversion. Equinus contraction. Positive Dutchney test. Ask the patient to plantar flex the foot while pushing up on the first metatarsal. Excessive supination of foot indicate superficial fibular nerve L4-S1 injury. Sensory loss of a dorsum of foot, superficial or first wave space deep branch. High stepping gait or slapping foot gait. Now the question for Viva. Why do you call it complete peroneal fibular nerve palsy? The patient has involvement of both superficial and deep component of fibular nerve. What do superficial and deep fibular nerve supply? The deep fibular nerve supply all muscles of anterior compartment of leg, namely tibialis anterior, extensor digitorum longus and extensor hallucis longus, along with peroneus tertius, fibularis tertius muscle. It takes sensation from the skin between first and second toe, the first wave space. Superficial peroneal fibular nerve supply fibular, peroneus longus and brevis muscles of the lateral compartment of leg and takes sensation from lower 2/3 of anterolateral leg and whole dorsum of foot except the first wave space. How do you clinically differentiate deep and superficial fibular nerve palsy? In superficial peroneal or fibular nerve palsy, the eversion of foot is lost, while dorsiflexion at ankle and toe will be preserved. While in deep fibular nerve palsy, ankle dorsiflexion will be lost while preserving the foot eversion. This is uncommon as both are commonly involved unless there is injury distal to bifurcation of common peroneal nerve. What are the causes of fibular nerve palsy? Trauma is most common cause of common peroneal nerve palsy. However, other causes are as follows: iatrogenic, knee arthroplasty, knee arthroscopy, hip arthroplasty, birth trauma, cast, other knee surgery, correction of genu valgum HTO, traction, varicose vein surgery, intravenous injection and infiltration, trauma, knee injury and fracture of femur, tibia, fibula, tibiofibular syndesmosis injury, knee dislocation and gunshot wound. Other bony exostosis, severe varus at knee, ganglion, Becker cyst, laceration, hemangioma, hematoma, synovial cyst, and weight loss. What is anterior tarsal tunnel syndrome? This refers to compression of deep fibular nerve under inferior extensor retinaculum that commonly present as paresthesia in first wave space of foot. What are the causes of foot drop? Foot drop can be broadly categorized into three groups. Number 1, neurological. Injury or neuropathy of common peroneal or sciatic nerve, disc prolapse at L4 L5 level, common peroneal nerve compression at fibular head, leprosy, multiple sclerosis, Charcot-Marie tooth disease, muscular injury to dorsiflexor of foot, toes, and tibialis anterior tendon injury, muscular dystrophy and polio, anatomic compartment syndrome, habitual cross-legged sitting, Charcot joint. What will you do next? I would like to get nerve conduction study of leg, radiograph of knee, and blood investigation to rule out other causes. What will nerve conduction study tell you? Only support diagnosis. No, apart from supporting diagnosis, they will help me determine regeneration of nerve fiber, assess site of lesion, and assess damage to nerve. Electromyogram additionally will help me in identifying peripheral nerve neuropathy, myopathy, and nerve radiculopathy, motor neuron disease, and peripheral nerve compression. How will radiograph help you? Radiograph will help me in looking for site of injury, fracture, osteotomy, etc., exostosis if any, and Charcot joint. Will you do anything else? Yes, I will evaluate for diabetes mellitus, liver function test, renal function test, and vitamin B12 level to look for metabolic causes. Also, if hematoma, aneurysm, ganglion, or Becker cyst is suspected, then I will get ultrasound done. How will you manage this case? As the nerve palsy is non-recovering and complete, so conservative management does not have a role. I will assess and discuss the functional requirement of the patient. The patient wants improvement in gait and dorsiflexion at ankle. I will correct equinus contracture at ankle by tendoachial lengthening and provide dorsiflexion motor by bridle procedure. What is the role of bony procedures? Bony procedure like gill posterior bone block can be done to prevent foot drop during walk in paralytic foot polio. If there is no acceptable motor, how will you do? I will explain the need of arthrodesis for providing painless foot with correction but no movement. I will prefer ankle arthrodesis unless there is arthritic change in the intertarsal joint.